Welcome everybody to this MS Academy webinar, where we're going to be exploring the integrated care services, specialised prescribing plans and MS. And we are supported today for this session by Roche. So we're going to be hearing about who are these new budget holders, how significant are they, how will the system work for MS prescribing, what are the opportunities and threats, and how will the new stakeholders and processes affect MS services. So my name is David Martin. I'm the CEO of the MS Trust, and I'm also chair of the Neuro Alliance. So now I'm going to introduce our esteemed panel. So first and foremost, and the person we'll hear from in a few minutes is Anusha Patel. So Anusha is the regional home care lead pharmacist for the East Midlands and a high-cost medicines pharmacist at the same time. We've also got Dr. Helen Ford, and Helen is a consultant neurologist at the Leeds Teaching Hospitals NHS Trust. And we've got Freddie Cavender-Atwood, and Freddie's the policy manager at the MS Society. So we're going to go in an order where we're going to hear first from Anusha about how these new ICSs are thinking about the integration of drugs. After Anusha, we'll hear from Helen and Helen Ford, and Helen's going to be talking about the socioeconomic aspects of emergency admissions in MS and why we now need more integrated services to understand the predictors of admission. And then we'll be hearing from Freddie Cavender-Atwood about how a focus on MS can actually assist with wider improvement goals. And then after we've heard from the three panelists, we'll then go to your questions and for a panel discussion. But before we hand over to our first of our panelists, I'm just going to share a couple of reflections from me and give you a sense of what I think is the enormity of the challenge we are all facing at the moment. I think what we can all do to stop MS being a Cinderella service in the NHS at the moment is critical. I was just looking at a couple of stats yesterday about where things are at the moment, where our red line is. Currently, of the CCGs, 35 out of the 195 CCGs have delivery plans that include neurological conditions. That's pretty damning, isn't it, really? Yet, at the last count from the Neuro Alliance in 2019, the Neuro Numbers report showed that the number of neurological cases has reached 14.7 million in England alone. 14.7 million. That equates to more than 1 in 6 people living with one or more neurological conditions. Now, as we're going to hear today, the NHS as we know it is evolving. There are great potential opportunities for neurology and for MS in particular, but as well as a number of challenges. Now, there are some great suggestions around those opportunities in the MS Academy report, NHS Reset and Reform, which inspired today's webinar, which I'd encourage you all to read. And I think we're going to try and get a link to that put into the question and answer box as well. But the advent of ICSs is a great opportunity. But at the last count, only one of the ICSs cited neuro as a priority. That's a challenge we all face. We must work to ensure neuro, and MS in particular, has a place in the priority setting discussions that are already taking place. So how are we going to do that? Well, let's ask our panel, starting with Anusha Patel, and how ICSs are thinking about the integration of drugs. Anusha.
Many thanks for the introductions, David. So I'm Anusha Patel, home care medicine lead pharmacist at Kettering General Hospital, and I'm also the regional home care lead pharmacist for the East Midlands, and I'm a member of the National Home Care Medicines Committee. I'm a high-cost drugs pharmacist, also based in the hospital that I work in, and I'm an embedded pharmacist for NHS England. I have a specialist interest in neurology, particularly within MS, and I work very closely with our consultants, Dr. Sunil Wimanaratne. I set up in the JB clinic. I'm training to be a Botox injector for chronic migraine. And I also look after MS. And we now are able to prescribe second-line DMTs at Kettering General Hospital. So I'd like to talk about how ICSs may think about the integration of medicines. And I will bring this from a secondary care perspective. So what I'd like to talk about is how were medicines funded prior to the pandemic? And this will be focused on MS in particular. What has the COVID-19 block payment brought to this and the changes that now impact upon our role? And my views on the future of high-cost medicines funding in MS specifically. So thank you for Roche for funding the development of this really amazing report, and I've had the chance to look at it, and I've taken out a key element of this, so from page 15 of the programme. And for me, it was great to see that these are the 4 key priorities that were highlighted. So clinical champions, and it mentions actually a neurologist, pharmacist to be there within the MDT. Operational consultant leads and consultant MSologists to work together with business managers. Again, my involvement is certainly more with my business managers when I'm looking for improvements in MS services. With commissioners, always have been there, but it's actually about engaging with them more so to ensure that we can achieve what they are asking for, and that redesign is provider-led and actually not commission-led. And I've just listed some bullet points here as to my views as to what this means. So there's definitely a lack of MS specialist pharmacists in our network. I've kind of evolved my role to be that point of contact for neurology. I'm certainly not employed or funded to do that. I do that out of goodwill. However, I believe that this will be changing, and we will start to see funding for neurology pharmacists coming to fruition. We all know that there is this hub and spoke model that is developed by NHS England, spokes being a centre like us, Kettering General Hospital, and I've had to do a shared care agreement to be able to initiate second-line treatments for patients so that they're not having to travel to hub. It's taken me 3 years to get to that position, and so these challenges are there, and I'm not funded to do that. It was something that I did in, I guess, awareness and experience of these patients that are actually just, you know, I'm not going to practice tell you what you guys know already. These patients they find it difficult in terms of mobility to go to a hub centre. So I wanted to ensure that they didn't have to do that, and also our transport links from Kettering to go to Oxford, Cambridge, Coventry, where we have the links with, aren't great either. So patients were having to pay for taxis actually to get to these places, and I felt that that wasn't fair for patients. There's also a variability in terms of this pathway. So as I've just mentioned, we were able to unlock access for second-line treatment at Kettering General Hospital, and I don't feel that every centre has the capacity or, I guess, support from pharmacy to be able to do that. And is this actually a priority within NHS England as specialised commissioners? I've read the report, and I was delighted to see some of the features within this. I'll just speak a little bit about, from my perspective as a pharmacist, as to what I feel that this means to me. So leadership, absolutely, it talks about leadership and integrated care systems. Where is that collaboration with pharmacy? And as we hold the budget, I would just ensure and hope that pharmacists, high-cost drugs pharmacists, chief pharmacists are part of this discussion when we talk about leadership. Another point was the pathway mapping, implementation, and innovation. Again, for me, absolutely great to read. Where do medicines fit into this? So when we talk about a pathway, in my view, it's a medicines pathway. However, this is a wider service provision. So just to ensure that high-cost medicines are brought into this pathway mapping. Commissioning and service management, again, great to see, link in with this, but as we're coming ICS, who are part of the budget stakeholders, and I'll speak about that shortly. I know I'm short of time, so I'll just skip on to people with MS, and that's the key focus here. This is about our patients, addressing the health inequalities that I've described today, that patients may have to travel, they may have to decline referral, and therefore what do they end up with? What care are they offered when they can't get access to hub specialist care. And PIFU, or patient-initiated follow-ups, are something that stands out to me in the report when I look at it in terms of, okay, our capacity is full in the NHS. NICE tells us that we need to review patients according to the criteria of the medicine that we're prescribing. However, is that necessary? And can we actually give patients a little bit more control as to when they want to access care? So PIFU is, in my view, a great idea. And during COVID, I think there's been definitely some positives to the block contract that was imposed upon us. I've developed as a pharmacist more relationships with service managers, business leads, when consultants are asking me for the introduction of new medicines at a local level. I'm still ensuring that I communicate with my commissioners, but I'm not actually asking them for approval. I'm just letting them know, because the money is there and it's for us to do what we want with that budget. It's been great to work with our clinicians, and they've certainly understood a little bit more about the role that I have and some of the pressures and responsibilities, and also direct reports that I have that wasn't there before the pandemic. I've definitely had more efficient ways of working with our teams, and as I mentioned before, I do a lot of clinics that I wasn't doing before the pandemic, and I never thought that I'd be an injector as I started as a pharmacist. And ultimately, I formed a network of high-cost shift pharmacists in our Midlands region to support sharing of ideas. Some of the future tasks that I think potentially could happen in terms of the role that I do and where I see commissioning going is, do I now need to look at all my pathways and guidelines that were previously approved by them, in the fact that now I've been asked as a lead high-cost pharmacist within pharmacy to save the hospital £100,000 as a CIP, so a cost improvement plan. Am I going to be scrutinising my pathways even more to look at where I can take some efficiencies? I'm certainly going to look at my last year's spend during COVID to see if there's anything there that I can potentially add to my CIP. Is there actually going to be a way now that we look at medicines introductions differently? So I chair our new medicines group at Kettwich General Hospital, and I'm also the lead formulary pharmacist. So all the roles that I've done in the last year as to what I look at when the medicines come into market, will that change? I suspect so. And also my monthly challenges that I get from commissioners, NHS England specifically, who will be doing those challenges with me now? Who is the lead within the ICS? Part of my role is to ensure that I provide patient-level data to commissioners in the use of high-cost medicines, and that's a huge challenge. And I don't feel that clinicians understand how much work we do. COVID's helped that when they're seeing what I do as my role. However, it's if we provide stock to award for a medication, but commissioners want to pay for that drug, they have to have patient-level data. So I provide it as stock, but in the background, I need a team to ensure retrospective dispensing, so that when I bill commissioners, they have a full line on that patient-level data. It's called the MDS data line. It's a lot of work. What's going to happen there if we move to an ICS? Am I going to actually work more closely with previously known as gypsies, but the GPs with specialist interests? Doctors. We know that there is a huge gap in terms of education within primary and secondary care for specialist areas. What about pharmacists? We have PCN pharmacists now working in GP practices, supporting GPs. Do we need to upskill those in terms of MS? And finally, I guess I've got a couple of minutes to go just in terms of the national tariff payment system that's been out for consultation. I've looked at that, and also a lot of members have in terms of home care as well. And some of the benefits or risks, I've separated them out. they mention an aligned and incentive approach to commissioning of high-cost medicines. So benefits for me is that actually, if we hold the budget, we're not asking for approval and we're not passing drugs through to commissioners, is that we have more control over what we'd like to do as an organisation. There's some terminology within there, so it's cost and volume. Cost and volume is essentially pass through, so we pass the drug cost through to commissioners, and this is still in place for Cancer Drug Fund, hepatitis C, a lot of other medicines that are potentially a risk to a hospital. For example, patients present to A&E that we don't know about, so blood products, patients that are bleeding with warfarin overdose is an example. We can demonstrate system-wide costs now to departments and specialities. So I have a separate monitoring system that I have that I can share with my clinicians to give them every month to say this is your drug spend. And we can decide, actually, this is the most exciting thing for me, that what's right for our patients, but also for our population. I sit on our population health management board, and I'm actually, as a pharmacist, it's great to say I'm being trained to do population health management, to understand health economics, to try to find out actually where should funding be prioritised to. Does this mean that we can remove IFRs in general? Can the local trust decide that we want to treat a patient based on compassionate grounds? Can we source funding from industry for that particular patient? IFRs, I'm sure everybody of you know, is so burdensome to try to complete the forms, but also demonstrate exceptionality or individuality when we complete these forms. Great to say the benefits, but there are some risks as well. So there is uncertainty for me, in my view, as to how will clinicians use new medicines. So I rely on going to clinicians to ask them when there's a new nice TA or there's a new medicine, and I go to commissioners to say, my consultants have told me that they may see 5 patients per annum. However, it may not be 5, it may be 15. Will I be able to account for that? Will consultants on the call, or generally wider, welcome more input from people like me at a local level, never mind at a management level? Will you want to engage with me? We're a new stakeholder, so I would hope that you would welcome us. Ascribe JSE, I mentioned here, if we skip down a bullet point, these are the pharmacy systems that we use to procure medicines dispensed to patients. We use these systems, and these are the systems that we use to then report to finance at month end. Can they cope with potential new requirements if NHS are going to ask us to do something differently? And overall, I guess I just worry that will pharmacy miss an opportunity at an ICS level in terms of medicines input? And I would welcome people to actually engage more with pharmacists as we look after the budget of high-cost medicines as an entirety, as opposed to individual neurology level, so that we can actually help raise the profile of MS services for our patients. So some key opportunities of getting right first time. The GIRFT programme is definitely one of those. And actually, can we change the model of a hub and spoke? Is there something different that we can do to allow spokes to be able to prescribe second-line treatment to ensure that patients get access to treatment? I've mentioned I'm on the board of population health management, and what I've learned from that is that savings from medicines are marginal in terms of actually looking at the wider piece, in terms of service costs, activity, and touch points when we look at an ICS model. So I certainly think that things will change going forwards. Thank you for listening, and I'm happy to take any questions.
Anisha, that was really informative. Thank you so much. And perhaps if I can suggest, there are already some questions about prescribing. So maybe let's hear from the other panelists first, then we come to the more broader questions at the end. And thank you also for highlighting the Reset and Restart report from the Academy. And that's already in your question and answer box at the end. So if anybody wants to download or grab the link for that, they can. Next, we're going to come to Dr. Helen Ford. Helen's going to be looking at the socioeconomic aspects of emergency admissions in MS and why we need integrated services. Helen, over to you.
Thanks very much, David. Okay, so this is possibly the longest title of any talk I've ever given, but we're moving away then from thinking about disease-modifying treatments to sort of more general issues for the population of people with MS. So here, just background really on social determinants of health and how that's influenced by many issues really from our childhood, housing, education, social support, our communities, our income and employment. And really just to think about how much this varies by area. So this is an example of male life expectancy comparing Blackpool with Westminster. And you can even just looking at the average life expectancy, almost 10 years difference between these local authorities. So COVID-19 has really shone a light on inequalities, I think, in the UK. And this is some data from Bradford, actually, looking at the critically ill people with COVID. And you can see the most deprived on the right, the most deprived quintile, really overrepresented in people with critically ill from COVID. So in terms of thinking about socioeconomic effects on MS, I just wanted to highlight this work, which is about the relationship between socioeconomic status and disability progression in MS. And this is a really nice study, which was led by Catherine Harding and linked obviously to the South Wales team and British Columbia, with over 3,000 people with MS. And it was looking at socioeconomic status at the onset of MS, and then looking at the disease course and progression, both to EDSS 6, 4 and secondary progressive MS. What is really important from this big population is that having a lower socioeconomic status is associated with a 9 to 10% increased hazard of reaching EDSS 6, and also for the 2 other outcome measures. So, you could say that actually higher socioeconomic status has a bigger impact on reducing disease progressions than some of our currently licensed disease modifying treatments. And I think this is important background for when we're thinking about the impact of emergency admissions. So also from the My MS, My Needs, just illustrating the real treatment gap. And if you look at the bottom of this slide, people with an income less than 25K, less likely to have seen a neurologist, be on treatment or access physiotherapy. So that's why it's so important that we're thinking about this whole population, because when I show you the data that we have on emergency admissions, these are the sort of issues that teams can help to prevent. Okay, so David will be pleased that I'm highlighting the MS Trust previous report from 2017, which focused on the main causes for emergency MS admissions, but also the huge costs involved. So we've done a recent project looking at deprivation and the impact on, and comorbidities and the impact on emergency admissions. And we presented this last week at the ABN, and this work was led by Ruth Dobson. So we're looking at all admissions, and we're going back to probably 15-16, which was the MS Trust report data, and comparing that to 2019-20. So you can see across the board a big increase in admissions. But then we looked at the most deprived people with MS. So looking at the quintiles using the English Index of Multiple Deprivation. And you can see that the increase is larger in all admissions for people from the most deprived group, and also in the emergency admissions. So really significant increase over the last 4 to 5 years. And then this is interesting. So we've looked at all of the neurosciences centres, the 24 neurosciences centres, and we've looked at their most deprived, the percentage of most deprived people with MS. So, and that varies hugely from 3% to almost 35% across neurosciences centres. And then we've looked at the emergency hospital admissions, and actually you can see that the percentage of the emergency admissions in the most deprived quintile is higher in many of the neurosciences centres than their percentage of people with significant deprivation. So this is looking at the odds ratios then of all of the different centres. It excluded Walton and Cambridge because of the absence of data. But you can see if you look over towards the right, this is factors for most deprived people with MS. So there's a significantly increased risk in these centres of acute admissions from most deprived people with MS. And this is the challenge that we're facing. Okay, and then the other thing we looked at was comorbidities. So these are the comorbidities in all admissions in blue and in the emergency admissions in orange. And so there's sort of two different important things about this. The first one, I guess, is reflecting the previous MS Trust data and the revisited data from 2019-20 in the reset report, is that disorders of the urinary tract are really common causes of admission. And then we also see digestive problems, so functional intestinal disorders are up there, and pneumonia, so respiratory disorders are there. But the other really important thing for us to notice is the impact of hypertension, tobacco, and type 2 diabetes. So these are all diagnoses associated with deprivation. Obesity, actually, you can see there too. So to summarize those findings, what we found in this study was a considerable variability across centres in emergency admissions for people with MS in England. In more than 2/3 of our neurosciences centres, patients who were most deprived were overrepresented in the emergency admissions. We've seen associations with those diagnoses of deprivation that I mentioned, so hypertension, type 2 diabetes, and smoking. But the important thing is, and this is the challenge for us, isn't it, is that these are largely preventable causes of a lot of these admissions. So it's a challenge, and this is why, you know, the integrated systems should be beneficial really for, you know, for dealing with this challenge. So in terms of integrated services, I mean, we've started some work already in Leeds. We've set up a new MS pathway group, jointly working with primary and community care so that we can work completely across these boundaries. Gail Metcalf, who's MS nurse in Leeds, and Audrey Owen in Huddersfield, Calderdale region, did a nice piece of work as part of their advanced academy, looking at can MS nurses reduce non-elective admissions, and in our areas we found UTI and sepsis were the main causes of emergency admissions, and they have got some really good initiatives around how we can work on that. One of those is a planned MS specialist nurse follow-up from every acute admission, so we are notified of every acute admission, and then personal care plans for, you know, introduced in the community using information from both the MS Society and MS Trust, but in really improving self-management. We've got a current business case for MS team expansion, and particularly based on the availability of new DMTs for progressive disease. And the other model that I think has worked exceptionally well over the years in Yorkshire and Humber is that we have had an expert advisory group for many years of the 5 prescribing centres. So this now links across 3 integrated care systems. So we have North, West and South Yorkshire. But I think that's been hugely helpful in terms of, you know, peer support, equity across our patch. So to finish, this is my final slide. I mean, I was really delighted to be part of the work on the National Optimum pathway. And, you know, from the start of this pathway, we were very conscious that a lot of this work isn't based on place. So if you look on the left-hand side, you can see it starts at the top with a person with MS, a GP and community team, local neurology services. But a lot of the work we need to do, so if we look right at the top for the person with MS and GP and primary care, you know, comorbidity management, symptom recognition, looking at these issues which can actually really reduce the impact on emergency admissions, I think. So, you know, my plea is that we continue to push to have this optimum pathway implemented. And then it helps us all across the board to have an in, really, when we're having conversations about integrated care, to say, you know, we have done this huge piece of work, and, you know, can we actually now start to implement this? So that's my plea. Thank you very much, David.
Helen, great presentation. Thank you very much. And maybe just leave the pathway there for a minute, because my sense is what I'm hearing nationally at the moment is that pathway is now definitely out of the long grass. And I think it's been used to inform some of the future work of the ICSs going forward. So for anybody who thinks the pathway is not important, I would say look again and have a close look at what it says, perhaps how that might help to improve your work going forward. But maybe there might be one or two questions on that going forward. Helen, thank you for a fascinating a presentation and some shocking statistics in there. And finally, for this moment, we've got Freddie Cavender-Atwood from the MS Society, and how a focus on MS can assist with wider improvement goals. Freddie.
Thanks, David, and thanks to Helen and Anusha for a really good presentation so far. Yeah, I've been asked to talk about how focus on MS can assist with wider improvement goals. So just, you'll know this, or many of you already, I'm sure, but just to say, the MS Society is, you know, one of the UK's biggest MS charities, and, you know, we're known for doing research, but we also do a lot of other things supporting people to live well with MS, and obviously a strong interest in this topic and integration and how to improve services. So so I've gone with a cheesy meme here to start things off. So I think really what I want to talk about, it's quite a simple point, really, and it is taken very much from the Academy's recent report that everyone's mentioned, hence why I have taken some quotes that really kind of make the point that I'm trying to make, perhaps better than I will, as you can see here, which is really that at the moment it is unclear exactly, you know, what level MS services will be commissioned and planned at, but as we've discussed, you know, ICS it's inevitable they're going to have an increased role. So it's really important that we get MS onto ICS's radars. And I think to do that, we need to make a case, as some of these quotes, you know, point out, a really strong case that improving management and outcomes in MS, and other neurological conditions really can help ICSs to meet their population-wide priorities. And those relate to some of the things that have already been touched on in the other presentations. Things like mental health, prevention, and delivering personalised care. You know, these are NHS England priorities, they're ICS priorities, and we need to kind of pitch MS as supporting them to meet those goals. And I think you could add inequalities to that list as well, as Helen spoke about. That's obviously coming out of COVID, even more of an area of concern. So I think as part of that, we need to also demonstrate that innovative approaches in MS care are transferable to other conditions. And I think we're in a strong place to do that. Again, Helen mentioned some, you know, great sort of work that's been going on her area to try and kind of rise to the challenge. I think some of that learning is transferable. And so, yeah, before I go on to talk about in a bit more detail about some of those areas, some of those priority areas where I think there's a synergy between what we will all want to see for people with MS in terms of improvements and what ICSs are concerned about. And just before I go on to that, you know, as David said, you know, why is this important? Well, because relatively few ICSs have referenced neurology services within their plans. So really, we need to be raising this and linking in with their priorities. And I think, you know, as well as making case for MS, it's neuro-wide is going to be much more powerful because the numbers will be on our side. Yeah, I think as I mentioned, you know, prevention is a big NHS priority, of course, and that includes reducing unnecessary emergency hospital admissions, as Helen spoke about. And she talked about the most up-to-date stats, and I've got slightly older ones on this slide. But it is associated with a higher and rising number of emergency admissions, which are, a lot of them are preventable. And I think Helen had, again, some great examples about what they're sort of doing to try and, tackle that. But I think there's a clear example of something that is costing money, unnecessary admissions. And actually, if you tackle that in MS, then you're going to be helping an ICS to kind of meet their targets overall. And just briefly as well, as part of prevention, smoking, actually a greater proportion of people with MS smoke compared to the UK average. And smoking makes you more likely to get MS and can make MS worse if you already have it. And the NHS England's long-term plan, has a long-term ambition that everyone admitted to hospital who smokes is offered treatment services, NHS-funded treatment services. So again, that's just one small example of where we know there is a bigger problem perhaps with people with MS and smoking. And so addressing that can help meet those wider goals. So turn now to mental health as another kind of ICS priority area. These stats on the left, it's taken from the Neurological Alliance's Patient Experience Survey from 2019, pre-pandemic, of course. And as you can see, kind of lots of people aren't getting the mental health support they would like. In fact, overall, they found 40% of survey respondents said their mental health needs aren't being met at all. And similarly, on the right-hand side here, you can see from the MS Society's My MS My Needs survey from 2019 as well, which surveyed over 8,000 people, found that there was also pretty high unmet need for emotional support compared to other kinds of support people needed. It was one of the highest. And again, mental health is a big priority nationally and will be for ICSs. So there's an opportunity there. So, the final area is around personalisation. Again, this is an NHS England priority. Their comprehensive model of personalised care talks about personalised care being an element in ICS plans, that ICS accountability and performance frameworks should, in the longer term, reflect this. And as you can see here from, again, the Neurological Alliance's patient survey, not enough people are getting personalised care. And it's not just a nice to have, it actually improves people's outcomes and as well as their experience. So again, this is an area where, in fact, people with neurological conditions are starting from a lower baseline than other conditions such as cancer when it comes to their care being personalised, being involved in their care and getting the information they need, having coordinated care. So there's an opportunity there to make the case that if you try and improve this for people with MS, you could kind of make a significant improvement overall. So I think that's my last slide. So in conclusion, basically, I think the point really simply is that if we're going to leverage changes to how services are commissioned and planned, we've got to get MS and neurology noticed by ICSs, and I think there's a long way to go on that. And we're going to have to work together to, as a sector, to really kind of make that case, and as clinicians and as people working in services. I think kind of in terms of the how do you do that, I really recommend the Academy's report. There's some great ideas in there, I think, to pick out, highlight some of those. Part of that is about identifying and developing clinical leaders. And, kind of Anusha talked about all the amazing things she's been doing to kind of push forward and drive improvements in her area, and it's not easy to do that. So I think, the report recommends, working to identify and support clinical leaders who can actively provide that leadership role and influence ICSs. And I think it also highlights that developing patient leaders is really, really important too. And unsurprisingly, as a charity representing people with MS, we would want to see that. And obviously, MS charities have a role in supporting that. And I think we've got some great tools to help us to get neuro and MS on ICS's radar. As Helen mentioned, the Optimum clinical pathway for MS. It kind of provides that template, if you like, about how to do integrated effective care. So I'd recommend that. There's also, it's a little bit old now, but NHS England's Right Care Toolkit for progressive neurological conditions actually has some of that. How do you really translate where we want things to be, and how do you actually do that, and some examples of good practice. And on that note, I think, again, in order to get ICSs to notice and to be able to do something about our concerns, we need kind of strong business cases against that pathway. We need innovative, best practice examples about how to do it. And I think there's so much going on in the space that we're in a really good place, but it's kind of bringing that together, sharing what we have, and making sure anyone on this webinar kind of can access that material and use it in their area. So just finally, at the MS Society, just to mention a few things that we're doing in this space, we do have a professional network that tries to share some of that best practice amongst clinicians. We've also got a program which provides professional evaluation support to selected services. So that's an opportunity for an MS service to kind of have funding to explore the impact that their service has on people's health and well-being, and thinking about how those models might transfer to other areas. So providing people with some evidence that might support them in making this case. So I will finish there, and thanks very much.
Freddie, thank you. That was really helpful, really informative, and a great bunch of panelists. So thank you for the Academy for bringing this all together. We've got about 15 minutes left. At the moment, I can see 7 questions in front of me. So I'm not. Maybe we can just get panelists to pick and choose a little bit which ones they're going to answer. First one, probably this. Anusha, this possibly got your name on it, but we'll see. In the past, prescribing has sometimes been called a postcode lottery. Will the new system improve this? Will it stay the same, or will it make matters worse, in the panel's opinion?
So yes, great question. Sorry if there's an echo. Can you hear me okay?
Mm.
Yeah. I certainly think that the ICS will improve the postcode lottery element. Reasons being is that if your trust hold the budget for the medicines that you prescribe, whether the drug is a hospital or not is no longer a factor, because it's still within your budget. There is nobody that has to be approved about, if you're prescribing a drug, you have to do it at a financial divisional level. So have those conversations with your departmental leads, with your managers. And once you have that conversation, there is no blue tech. Well, actually, no, I take that back. Blue tech will remain. Patient data is necessary. However, there's no commissioner approval as such to start patients on medications that you want your patients to start on. So ICSs will certainly, in my view, improve your prescribing for patient access.
Okay, anything else to look and see as other panelists want to come in? Nobody's going to agree or disagree, so thank you, Anusha. Thank you very much. All right, I'll go on to the next one. Anusha, it's possibly in your area, but also other panelists, feel free to come in. It's great to see the role of the neuro and MS pharmacist championed, but the questioner notes that the diagram setting out stakeholders for service transformation didn't mention either MS nurses or allied health professionals. The questioner says MS nurses particularly are integral to setting up local DMD services, as well as delivery and implementation. Where does the panel see the role of the MS nurse in the context of DMD service improvement and transformation? And obviously, coming from the MS Trust, it's something particularly close to my heart.
I can start on that, and I hope the panelists can add. So, gosh, I work so closely with our MS nurse, and she has been the driver to, I guess, make me do the work that I've done to ensure that MS patients have access to services. They do the monitoring. It's, a shared agreement. All the work that I've had to do and put into the background as to having sign-off from commissioners has been led through the nurse. So I had to do an appendix as to what the nurse does to get actually sign-off for them to be able to prescribe medicine. And it seems so silly that I was the one doing that, but actually, again, you mentioned the word champion. there has to be a champion to be leading the uptake of MS medicines within a trust. And yes, it landed upon me, but it doesn't have to be me. I think the nurse is a great healthcare professional to be able to do that, because they're seeing it day to day, and I've seen the frustrations that they have. I'll leave it there.
Okay, panelists, anything else you wanted to add? Helen?
Yeah, I definitely want to add, you know, I highlighted some of the work that our MS nurses have been doing in our region. And I think that they are constantly working on service development, and we're always trying to get better. And that is very often driven by the MS nurses. And I think in terms of these challenges, and especially coordination, integration, I mean, that's such a key part of the MS nurse work. So the work that we've done on emergency admissions has been very much MS nurse led, linking with both, you know, the acute wards where people with MS often end up having their admissions, but also linking in with primary care and trying to avoid repeat admissions. So yeah, and then going on to the neuropharmacists, I think absolutely there needs to be a bigger role for neuropharmacists in our teams, and I think that, you know, they need time set aside, because a lot of the neuropharmacists are covering all neurological services, not just MS, and MS has grown hugely. So yes, I mean, absolutely crucial that we recognise the role of both the nurses and the pharmacists in transformation.
And we've also been asked as well, what role do the panel think that practice clinical pharmacists will have in MS management in the future? Does anybody have a view?
I guess I'm going to have to take this one. Practice clinical pharmacists, is that PCN pharmacists? Sorry.
Just describing the question as practice clinical pharmacists, I'm afraid, Nisha.
I'll answer the question if I'm understanding that this says GP pharmacists, so pharmacists based in GP practices. We need to educate pharmacists in primary care on this condition. It's not fair for us to say that, oh, there's a huge unmet need and patients are not treated well in community if we don't provide that education. And so there is work to be done, and it is happening via the CPPE and the UKCPA to ensure that pharmacists are educated in MS. I think it's a wider piece of work, so I'm reading on biologics in general and home care medicines. I think that's where we need to start off with, and then we can start to focus on some of the specialist indications. It's a huge piece of work, but we didn't know that ICSs were going to be, you know, this is where we're going to be. So let's educate the whole sector so that also not only patients are supported, but healthcare professionals can bounce in and out of primary care, secondary care, so that they can also do what they want to do in terms of career progression as well. And that's another topic that we could talk about. But
Okay, what I'm going to do now is broaden out the discussion a little bit. One of the things, and when you read about the ICSs, is the increased priority on place. We've got a really good question here saying it's increasingly important to understand that geographical responsibility within place-based care, and particularly how MS centres fit into local systems and this place-based care. How do the panel think this will develop in the future?
I think that's a difficult question.
Yeah.
I'll attempt. I think at the moment there's so much that we don't know, and I think NHS England has just started, you know, kind of engaging about, you know, kind of the nature of specialised services going forward, and I think there's a lot of conversations still to be had from a very much kind of, you know, a national policy perspective to understand that. It might look very different to other panelists, but I think for us, we've still got so many kind of unknowns that we want that engagement to happen sooner rather than later, because these reforms are moving on apace and things will be changing on the ground. And if we haven't got kind of a service specification that is fit for purpose and things, then I think you could see inequalities sort of widening and that regional variation.
Helen, what are your thoughts on this?
Yeah, I mean, the other thing that I think we need to think about is, much as we're talking about integrated care systems, they don't include the local authority, do they? And so, I mean, a lot of, in terms of thinking about some of the factors which fall outside healthcare systems, and particularly in the drivers of social deprivation. So, I think a lot of areas may have health and well-being boards, and it may be that, we need to be thinking bigger than just the integrated health systems, which in a way we've been working with, changes in integration of health for many years, but actually what we need is a properly place-based link of all health services and local authority as well, including public health.
Helen, you talked then about broadening this out beyond the ICSs, but one thing in particular that's been touched upon today in your presentations was about patient-initiated follow-ups for PIFUS. So this brings particular challenges for people living with MS and for MS services to roll out effectively while ensuring that everyone receives the right care at the right time. What are the views of the panel around the rollout of PIFU at the moment?
So I can start briefly on that because we've just started that actually in our trust. So we've just introduced it, and I actually thought that the MS service was an ideal place to trial this. So I mean, and so the people with MS I've talked to about it so far have been quite enthusiastic about the idea, but I think you have to be very careful that this is not something that we can just introduce broadly across the whole MS population, because the risk is we broaden or widen inequality, so that this will suit some people with MS. It won't suit everybody, and we need to be very careful about widespread adoption without thinking about the individual person with MS.
And Freddie, is there a view? Do you have a view of the society?
Yeah, I think I'd echo very much what Helen said. I think it's not something that I know there's some sort of Neurological Alliance-wide work going on to understand, how patients feel about this and how they experience it, which is kind of ongoing. But definitely the concern is my concern would be if someone has kind of cognitive issues and they're getting worse over time and they're in this sort of system, then how will they actually take that initiative? Will they be activated and get back in touch to seek the care and or the conversation that they need? And I haven't really kind of heard an answer to that, but I've definitely heard a lot of clinicians saying they think it will be helpful and think it can work. So I guess I'd kind of like to hear possibly more detail about how those safeguards are in place and how it is individualized, as Helen was saying.
Okay, I've got a couple of technical questions for you, very brief ones, before I've got one stink of a question to end on. So I'll just warm you up there. So first of all, Anusha, no, I'll go to Helen first. How was the data collected, Helen, on the emergency admissions, and how reliable is this data? That came up during your presentation. Sorry, I've only just got to it now. Did you get that? Okay,
so this is HES data, yeah. So it's was collected through Wilmington Healthcare, have collected all of the data. So yeah, there are some concerns about the data from some organisations, especially because the models of neurology are very different. So some centres are hyper tertiary centres really, and probably don't have the same sort of local population admissions perhaps. So I think, yeah, I mean, obviously there will be some variability, but it is based on HES data. Yeah.
Okay, that's really helpful. And then I think a quite straightforward question, and I think the answer, this can't be answered, but how does the panel think blended payments will affect prescribing MS in the future? Anusha, is there any insight you can throw onto that?
Yes, so I guess blended payment system is new to everybody. We're trying to not call it that as an emergency, we're not terming it that. So let's wait and see what they call it, but it's definitely aligned and incentive payment system that we're working towards. And there's certainly a new process that we're looking at in terms of high cost medicine. So it's no longer going to be high cost medicines, it's going to be a tiered approach, okay. which is very clear. I guess that's all I can say.
All right, that's helpful. And then the final question that's come through this morning, this lunchtime, is it's addressed to you, Anusha, but I think I'm going to ask each member of the panel to answer this, or give a short answer to this, is how do you see management and individual leadership in health over collective collaboration and citizen-wide autonomy in medicine?
Wow.
Do you see that changing fundamentally as we move forward to ICSs, or is that a bigger question than that?
Helen, do you have an answer? But to follow on from somebody.
Yeah, are we expecting too much of this change? I mean, I don't know that ICSs will fundamentally change that, but I think the world is changing, isn't it, in terms of autonomy and people with conditions becoming much more powerful advocates, and that is helpful. But I think what we've got to be doing is working in partnership. And I think the other thing is I'm not sure we're strong enough as MS by itself. So I think, you know, when David said about the number of CCGs whose delivery plans even include neurology, I think grouping together, you know, across conditions and across people with neurological conditions has to be the answer, really, because I don't think we're going to get ourselves on the agenda as a single condition lobby.
Freddie, do you have a response to that?
Yeah, I mean, it could kind of incorporate a lot that question, couldn't it? But I guess to echo Helen, that these, you know, legal changes aren't going to make things happen. I think, you know, one of the things that a lot of commentators have said about the reforms is you can't legislate for culture change, you can't legislate for relationships, and so much of delivering integrated care and all the improvements we want to see is about relationships and a lot of the things we talked about. So I think I'm a bit concerned with the legislation as it is, that it's not strong enough on that patient voice actually needing to be at the heart of decision making and planning of services. So that's something, you know, a number of us charities are lobbying on. Yeah.
Super. Well, my dog's biting my ankle underneath the dining table, which is telling me it's 1 o'clock. So that must be the end of our session. So can I say thank you to Anusha Patel, Helen Ford and Freddie Cavender Atwood. It's been a compelling session. For those of you who are watching at the moment, perhaps if you want to recommend it to your friends, that would be appreciated. And again, can I thank Roche for their support of this session. Thank you, everybody, and have a good day.